Hello everyone, myself Dr. Rucha Dashrathi, a fellow under Dr. Jayaprakash Shah at Rajni Fetal Medicine Center, Ahmedabad. My topic for case presentation for today is short rib polydactyly syndrome, which is a known skeletal dysplasia. So my patient Mrs. ABP, 20-year-old primigravida with a consanguineous marriage came to us at 24 weeks of gestation after a malformation scan suggestive of short long bones. When we did her ultrasound, we found that the findings from the previous malformation scans were matching. That is, short long bones were present, as we could see over here that the bones are parametrically short, all of them going parametrically under less than 1 centile. Also, we could see a curvature, curved long bones over here. Next, as we took the image of the spine, it was because we were suspecting thanatophoric dysplasia, so we wanted to rule out platyspondyly in this case, but we could see perfectly arranged vertebral bodies, a perfectly seen spine, but the ribs were short. As we could see over here, the abdominal and chest circumference, we could see that the ribs are reaching less than half of the chest circumference. Also, there is presence of a thoracic dip. This is indicative of thoracic hypoplasia. Going up further, as we could took a 3D rendered image of the limbs, we could see that the limbs were short, but the digits were perfectly normal. This was suspected to be thanatophoric dysplasia and hence termination was advised for the patient. So after termination, the pictures of the abortus was sent and no autopsy was carried out. However, the pictures of the abortus confirmed our diagnosis. We could see that there was presence of short ribs, the short limbs. The limbs are hardly reaching up to the level of the abdomen. Short ribs are present. There is a thoracic dip which is pronounced, very pronounced and seen. However, we had missed one finding in this case, that is the presence of polydactyly into the left limb. So as we revisited our images, we could see that there was presence of polydactyly. We could see that 6 digits were present over here. Also, the X-ray of the abortus was taken out and the findings again were confirmed. We could see curved long bones, we could see short ribs present, a perfect well-defined spine was seen and a thoracic dip was also seen. This helped us to reach a diagnosis of short rib polydactyly syndrome. However, earlier as we were suspecting thanatophoric dysplasia before the termination of pregnancy, amniocentesis was done and only FGFR3 mutation, only the report for FGFR3 mutation analysis was sent. However, when we came to know after abortion that it is short rib polydactyly syndrome, we sent a whole exome sequencing and the report came out to be positive. We could see that there was a pathogenic variant present on exon number 8. The mutation of the gene DYNC212 was over there in homozygous variety in autosomal recessive inheritance. And also there was presence of a likely pathogenic variant on exon 84 that was present with again an autosomal recessive inheritance. Later on, the DYNC212 gene targeted mutation analysis report was sent for the mother and father of the fetus, and which came out to be positive for the gene mutation and showed an autosomal recessive inheritance with heterozygous mutant. Therefore, giving us a diagnosis that both the mother and father were carrying the gene mutation which came into the fetus. Going on to the discussion part, short rib polydactyly syndrome is a heterogeneous group of disorders. It is inherited as an autosomal recessive trait and hence has a 25% recurrence rate. It is extremely rare in incidence with an incidence of 1 in 5 lakh live births and has a female preponderance. The genetic basis of short rib polydactyly has not yet been elucidated. However, few studies have been done, out of which one I could find which suggested a pericentric inversion in chromosome 4. The short rib polydactyly syndrome has four gross features, that is short limbs, that is micromelia, short ribs, thoracic hypoplasia and polydactyly, and along with it a few other multiple anomalies are may or may not be present in major organs. So the study that I was mentioning earlier, short rib polydactyly syndrome and pericentric inversion of chromosome 4 by McGill-Aroste, suggests that there is a pericentric inversion of chromosome 4 with breakpoints in P16 and Q12 or Q13, which were observed in this study. Going on to the subtypes of short rib polydactyly syndrome, there are four subtypes. Type 1 is Saldino-Noonan syndrome, type 2 is Majewski, type 3 is Verma-Normoff, and type 4 is Beamer-Langer. Going on to type 1, that is Saldino-Noonan syndrome. As we could see over here, there is presence of polydactyly in 95% of these cases in type 1. Also extremely short ribs leading to thoracic hypoplasia, further leading to pulmonary hypoplasia is present. Short bones with pointed and narrowed metaphysis are present in cases of type 1 Saldino-Noonan syndrome. Also certain systemic anomalies, that is cystic kidneys, GI atresia, anorectal anomalies and CSDs may be present along with diffuse hypomineralization. In type 2 Majewski syndrome, this is a short video from the FMF website which shows narrow chest, that is denotes thoracic hypoplasia. Also it shows short ribs, short and horizontal ribs are seen, which also denotes thoracic hypoplasia in this case. Also, now this case will have an additional characteristic feature, that is midline cleft lip with or without cleft palate will be present. So facial clefting will be present. It could also be associated with cleft tongue, oral frenulae, natal teeth or epiglottis abnormalities. Again, the gross characteristic feature of polydactyly will be present over here, and short limbs or micromelia with a short ovoid tibia will be present. Ambiguous genitalia may or may not be seen in these cases, and there will be associated CNS abnormalities, which is again a distinguishing feature, that has pachygyria, then Vermian hypoplasia, absent olfactory bulbs, arachnoid cysts, corpus callosum agenesis and arheinencephaly. Coming on to type 3, that is Verma-Normoff syndrome. It resembles type 1 in its features, that is short ribs, short long bones, thoracic hypoplasia and polydactyly, which are the four gross features. But the distinguishing feature is that there is absence of midline clefting and presence of metaphyseal spurs or shortening of the base of the skull. Now in this picture we could see a metaphyseal spur that at the end of the metaphysis could be seen in both the pictures. Also poorly ossified vertebral bodies due to hypomineralization will be seen in these cases, and association of cystic kidneys or ambiguous genitalia will be there. Coming on to type 4, that is Beamer-Langer syndrome, it resembles type 2 in its feature. Midline facial clefting is present in these cases. Shape of the tibia, however, differs from the ovoid shape in type 2. And short and bowed limbs are present, dysplastic kidneys will be seen, and the distinguishing feature is that there is lack of polydactyly. Coming on to the ultrasound diagnosis of short rib polydactyly syndrome, as we discussed, the four characteristic features, that is short and horizontal ribs, short long bones, that is micromelia, a narrow thorax giving the abdomen a bell-shaped appearance, and polydactyly will be present. In type 2 and 4, midline facial clefting will be present, hyperextension of the head and neck will be seen, large echogenic kidneys could be seen. The association with congenital heart disease, most commonly transposition of great arteries will be present, anophthalmia and certain brain abnormalities as seen in type 2 will be present. Going on to a differential diagnosis of it, certain skeletal dysplasia could be differentially diagnosed, like achondrogenesis, which will have the presence of hypomineralization in spine, pelvis and calvarium. Thanatophoric dysplasia, type 1 will have bowed femur, type 2 will have clover leaf skull. hypophosphatasia, which will have a clavicle sparing hypomineralization, osteogenesis imperfecta type 2, which will have fragile bones with diffuse fractures, Ellis-Van-Creveld syndrome or condoectodermal dysplasia, which will have dysplastic nails and teeth. Then Jones syndrome, which will have asphyxiating thoracic dystrophy. Then Meckel-Grubel syndrome will have presence of postaxial polydactyly, occipital encephalocele, and cystic kidneys. Trisomy 13, which will have no severe dysplasias present but will have an association with polydactyly. Now, in case if we find the ultrasound features of micromelia and short ribs that are present, then we go further to look ahead for polydactyly if it is present or not. If it is not present, then we can lead to a diagnosis of type 4, that is Beamer-Langer syndrome, which shows lack of polydactyly but presence of other four gross characteristic features. If in case polydactyly is present, then we examine the face and see if there is median cleft lip present. If it is present, then we examine the long bones. If there is presence of an overt shape of tibia, the diagnosis is type 2, that is Majewski's syndrome. And if the tibia is longer than the fibula, again we go for a diagnosis of type 4. However, polydactyly should not be present in this case. In case the median cleft lip is absent, then we are left with the diagnosis of type 1 or type 3. So if we see that the bones are pointed with narrowed ends, then it is a type 1 diagnosis. If there is presence of marginal spurs or metaphyseal spurs, it gives us a diagnosis of type 3. Coming on to the prognosis and outcome of it, the ultrasound findings are gold standard for the diagnosis of skeletal dysplasias, especially short rib polydactyly syndrome. However, diagnostic fetoscopy could also be done. Amniocentesis has to be done to rule out the chromosomal abnormality as the basis for dysplasias. It will have a poor prognosis, an invariably lethal condition in most of the skeletal dysplasias will be seen. However, if there is short rib polydactyly syndrome, we have to differentiate it from chondroectodermal dysplasia and asphyxiating thoracic dystrophy, as they are compatible with survival for life. Autopsy and radiological confirmation of USG findings to be done after termination, which gives us the end result or the end diagnosis. If we are doing an X-ray of AP and lateral view of the skull, spine and chest has to be done. Also, AP views of upper limbs, lower limbs and pelvis has to be done. And in case of a short rib polydactyly in this pregnancy, we have to remember for an early ultrasound diagnosis in the next pregnancy. Also, a multidisciplinary approach with the clinical geneticist should be involved in case of next pregnancy. Prior to the next pregnancy, opinion of a clinical geneticist should be taken. Now, this is a checklist for skeletal malformations. In case if we have a previous pregnancy with skeletal dysplasia, or we have an accidental finding of short or bowed long bones, we go for a checklist of skeletal malformations to be diagnosed. So we will measure all the long bones, then we'll compare with the other segments and classify the limb shortening as rhizomalia, mesomalia, acromelia and severe micromelia. Now, rhizomalia will be suggesting the shortening of the humerus and the femur. Mesomelia will be suggesting the shortening of the radius ulna and the tibia fibula, while acromelia will be the shortening of the hands or the feet. And complete shortening of all the three segments will give us micromelia. A qualitative assessment of the long bones has to be done. That is, if there is presence of bowing, hypomineralization, fractures, metaphyseal flaring and absence of bones if any, like in radial reaplasia. Then measurement of the chest dimensions has to be done to rule out thoracic hypoplasia. Then evaluate the hands and feet to see if the digits have polydactyly, syndactyly, clinodactyly or any of it. Then positional deformities should be looked for. Then the cranium should be evaluated to see if there is macrocrania, shortening of the skull base, like in short rib polydactyly, frontal bossing, clover leaf skull like in thanatophoric dysplasia, and hyper and hypotaylorism should also be looked for. Facial midline cleftings, which are a part of a lot of skeletal dysplasias, have to be seen. Spine has to be evaluated for platyspondyly, hypomineralization and vertebral disorganization. Then evaluating the major organs has to be done to see the association of any systemic abnormalities. Also an echocardiography has to be done. Fetal movement and amniotic fluid volume also have to be looked upon. So as mentioned earlier, we could see rhizomelia, that is shortening of the humerus, or the femur mesomelia, shortening of the radius ulna or the tibia fibula, and acromelia for the hands and feet. Also in case of polydactyly, postaxial polydactyly will be on the ulnar side while preaxial on the radial side. In cases of thoracic hypoplasia, we have to look for the following differential diagnosis, that is thanatophoric dysplasia, Jones syndrome, hypophosphatasia, achondrogenesis, short rib polydactyly syndrome, osteogenesis imperfecta type 2, and condoectodermal dysplasia. In cases of micromelia, following will be the differential diagnosis, that is thanatophoric dysplasia type 2, hypophosphatasia, osteogenesis imperfecta type 2, achondrogenesis, and short polydactyly syndrome. Thank you so much for your patient listening. Thank you.